How often do you see a case of hypertension in a pediatric ward? So this is a case of 5-year-old child diagnosed with hypertension in this age, that is pre-pubertal age, that to less than 6 years of age. Most of hypertension cases have secondary causes, that is secondary hypertension. But which cause do you rule out first when you have these many causes? But we have very simple algorithmic approach where we have to do only 5 initial investigations. From that, we can rule out almost all these causes. Those 5 investigations include: the first one is plasma aldosterone and renin activity. The second one is plasma and urine catecholamine levels. Third one is renal imaging. The fourth one is renovascular imaging. And the last one is sleep studies. By doing sleep studies, we are trying to rule out obstructive sleep apnea as a cause of secondary hypertension. And by doing renovascular imaging, we are trying to rule out renal artery stenosis. By doing renal imaging, we are trying to rule out any abnormalities or scars present on the kidney. Plasma and urine catecholamines should be done to rule out pheochromocytoma and neuroblastoma. Both of these cases have increased catecholamine levels. Because of that, there will be headache, sweating, and tachycardia, a triad of symptoms. And the last investigation is plasma aldosterone and renin activity. By doing this investigation, we divide patient into two groups. The first one, the second one. First group, increased aldosterone levels, and the second group, decreased aldosterone levels. In a group of increased aldosterone levels, there are three causes. First one, congenital adrenal hyperplasia. Second one, glucocorticoid remediable aldosteronism. And the last one is aldosterone secreting tumors, that is very rare. And if there is a decreased aldosterone levels, there are a set of syndromic causes, that is Liddle syndrome, Gordon syndrome, and apparent mineralocorticoid excess. And the last one is renin secreting tumor, that is very rare in this age. And we are left with these four syndromes. These four syndromes are known as Mendelian forms of monogenic hypertension. To diagnose these causes, we should do serum potassium levels and ABG. If serum potassium levels is high and ABG is showing acidosis, that is the combination of hypertension, hyperkalemia, and acidosis, is seen in Gordon syndrome, which occurs because of increased activity of sodium chloride symporter in distal convoluted tubule. And if you find hypokalemia and alkalosis along with hypertension, that is a combination of hypertension, hypokalemia, and alkalosis, then the remaining causes, that is Liddle syndrome, glucocorticoid remediable aldosteronism, and the last one, apparent mineralocorticoid excess. This will be the cause. In Liddle syndrome, there will be increased activity of epithelial sodium channels. In glucocorticoid remediable aldosteronism, instead of renin and angiotensinogen, aldosterone is being controlled by ACTH. Because ACTH is stimulating aldosterone, aldosterone will be released in excess amounts. Because of that, there will be increased activity of principal cells in cortical correcting duct. And the last one, apparent mineralocorticoid excess, which occurs because of deficiency of 11-beta hydroxysteroid dehydrogenase, that is 11-beta HSD type 2 enzyme, which is present in the kidney. This enzyme will be defective in apparent mineralocorticoid excess. So the conversion from cortisol to cortisone will be defective. Since the cortisol levels are increased in kidney, and cortisol has both mineralocorticoid and glucocorticoid action, cortisol will stimulate mineralocorticoid receptors. So Liddle syndrome, glucocorticoid remediable aldosteronism, and apparent mineralocorticoid excess, all these three syndromes occur because of increased activity at principal cells of cortical collecting duct. So to rule out all these causes, you should do genetic testing. So this is a simple and complete algorithmic approach to the secondary hypertension in pediatric patients. Thank you.